Good morning, Dr. Rusch. I want to thank you and the American College of Surgeons for the opportunity to interview you today and this tremendous event honoring you as the American College of Surgeons icon of surgery.
Oh, thank you. It's a pleasure and a privilege to be here.
So many people have met you, but I think very few actually know very much about you. Like the fact that you're fluent in 3 other languages and considered actually becoming an interpreter. So I thought it would be nice to actually start a little bit about your early life.
I was very fortunate to have parents who really placed a great emphasis on high quality education. My father's family background is Swiss, and my father was trilingual, although he was born and grew up in this country. And he felt that it was very important for us 3 kids to have a multicultural, multilingual background. And so in order to achieve that, I was sent to the Lycée Français here in New York, which is a French school where the primary language is considered to be French, and you're obligated to study at least 1 or more additional languages.
You've achieved so many milestones, like you have served as chair of the American Board of Thoracic Surgery, you were a council member on the American Association for Thoracic Surgery, then you were chief of thoracic surgery at Memorial Sloan-Kettering Cancer Center, a regent for the American College, and then ultimately the college's 100th president. All roles in which you were the first or one of a handful of women to serve, which I know that you have talked about the fact that your father played such a role in that in terms of encouraging you to think his comment about, no one can argue with excellence is clearly true.
Well, I'll step back for a moment and say that my mother was a feminist before that term was in general usage. And she not only prioritized education, but she really emphasized continuously to me and my sister that we should excel at whatever it was that we wanted to do, and that while we might encounter barriers, that we should just move past those. And my father really did see excellence as a path forward when there were barriers or hurdles. And I can't remember exactly whether it was trials and tribulations in med school or other experiences, but I really have never forgotten that phrase.
When did you kind of know that treating lung cancer was something that you wanted to do?
I went to the University of Washington to do my residency in general surgery and then cardiothoracic surgery as a general surgery resident. We were seeing a very substantial number of lung cancer cases, especially in the VA population. The University of Washington was a member institution within the Lung Cancer Study Group, which was an NCI-funded cooperative group, really the first surgically based multidisciplinary cooperative group focusing on clinical trials in lung cancers. After I finished my cardiothoracic residency, I decided that I was a little bit more interested in doing general thoracic than cardiac, and by serendipity ended up going to MD Anderson.
And so what kind of was that experience like?
Well, there were really 2 types of exposures that I think were prompted a fundamental shift in how I looked at thoracic surgery. One, of course, was that Cliff Mountain was instrumental in creating the lung cancer staging system. And primarily the evidence came from a registry that he had developed at MD Anderson. And so that was my first exposure to a very systematic approach to staging and treating lung cancer. The other experience at MD Anderson was an intensely multidisciplinary approach. And in fact, the thoracic surgery clinic was a combined clinic done in collaboration with thoracic medical oncology. And at the end of every clinic, we would sit down together and have a mini tumor board and discuss all of the patients and think about clinical trials and what was optimal patient care, et cetera. That was an eye-opener.
Then you return from MD Anderson back to University of Washington as an assistant professor and join faculty there. And you meet another great mentor and sponsor.
So this was another moment of serendipity, because while I was at MD Anderson, Bob Livingston was recruited to lead the Hem-Onc group at the University of Washington. And at that time, he was chair of the lung committee in the Southwest Oncology Group, another one of the NCI-funded cooperative groups. Bob approached me and said, well, I'm really overwhelmed with other responsibilities, and I'm currently serving as the co-PI for the LCSG, and would you like to have that position? And oh, by the way, we also need a surgeon leader in the lung committee of the Southwest Oncology Group, and I have trouble finding surgeons who are interested. And I, of course, said, sure. Bob really mentored me in how to write a clinical trial, how to conduct a clinical trial, and he opened the door for me to participate at a national level.
And then Dr. Martini was chief of thoracic surgery at Memorial Sloan-Kettering, calls you in 1988 saying they're looking for a thoracic surgeon, and that he was given your name by Bob Ginsberg. And within 6 months of you joining the faculty, then you have a new chief, and that new chief is kind of none other than actually Bob Ginsberg.
Niall Martini and Bob Ginsberg had been colleagues and friends. They'd known each other for a long time. And as Niall Martini was ill and increasingly disabled, the search was afoot to look for another chief of thoracic surgery. But I actually didn't know that when Martini called me. And I was not looking for a job, but I also was working extraordinary numbers of hours, covering many hospitals across the Seattle area, the university, the VA, covering trauma at Harborview, and I was very concerned about whether I would be able to move my academic career forward. And I was increasingly interested in oncology and decided that it was time to focus down on thoracic oncology, and the MSK opportunity was the perfect one at that point in my career. So again, another career shift totally by serendipity, which turned out to be very fortunate.
And can you talk a little bit about those early years at Memorial?
The group at MSK, of course, was very expert in thoracic oncology management. Niall Martini and Dr. Naruke were responsible for developing the first lymph node map. When I arrived there, Martini was along with Richard Gralla, was leading one of the first and most important neoadjuvant therapy trials in stage 3 lung cancer. And that was based on a very meticulous analysis of their experience operating on patients with N2 disease who had not had neoadjuvant therapy, and figuring out what the 5-year survival was for patients who had bulky multi-station disease as opposed to microscopic disease, single-station disease. So it was really a vibrant environment in terms of lung cancer management and thoracic oncology.
It's almost prescient when you look back and you realize there's this serendipitous connections with Mountain and Livingston and Martini and Ginsberg. But in retrospect, you were at the beginning of kind of modern thoracic surgery, and it was developing around you.
Each one of us, if we're fortunate, has a career span of 30 years or so. And you have to think about what gets you up out of bed every day. It's probably not becoming the chair of a committee somewhere or becoming a department chair. It's because whatever you're doing each day presents an interesting clinical conundrum or an intellectual challenge, especially the latter, that you want to address either because you're doing laboratory investigation, clinical research, or translational research.
And I really like this picture because I can relate to it, which is the picture of the Memorial Sloan-Kettering chiefs, service chiefs. And you were the first woman to be named a service chief at Memorial Sloan-Kettering. So congratulations, and thank you for inspiring so many of us. Can you tell us about your early years as chief?
One of the goals that I had as a service chief with respect to my faculty members was to try to provide them opportunities that would align with their interests. If I'd had different mentoring, and if I had my career to do over again, I would go down the physician-scientist path.
You've had a profound impact on the principles of multidisciplinary care and translational clinical trials. Can you tell us about some of the trials and key discoveries that you have been involved in?
I was, of course, very involved in neoadjuvant therapy, single-arm trial, testing the use of 3 or 4 cycles of platinum-based therapy prior to resection in patients who had clinically evident N2 disease. But then I also co-led a trial in the Southwest Oncology Group. Subsequently, that trial was expanded to the Radiation Therapy Oncology Group as an intergroup trial, examining whether the addition of surgery to neoadjuvant chemoradiotherapy would lead to a benefit in overall survival.
I've watched several of your lectures where you've really talked about this evolution of lung cancer care, which goes from kind of safe surgical techniques to kind of the current molecular era.
Yes, I think that what's really amazing has been the Venn diagram. And that Venn diagram is the confluence of technological advances and biological discovery. And then the development of novel therapies to address advances in our understanding of tumor biology. And in the last 20 years, it's been just an absolutely amazing evolution, because prior to about 2004, lung cancer was not the cool kid on the oncology block. We had really virtually no understanding of lung cancer biology. We had rudimentary, slowly improving staging methods, etc. But if you think on the surgical side, that what was happening through the 1990s was the development of minimally invasive technology to allow us to do first VATS and then robotic. And the advent of EBUS and then robotic bronchoscopy. So we've had this major technological evolution which has transformed surgical care. And then on the biology side, the discovery of oncogenic driver mutations. And following that, the discovery of the immune pathways that can be modulated through the current agents that we use today, like the immune checkpoint inhibitors, pembrolizumab, nivolumab, etc. And so the fact that those two things were happening separately but simultaneously and came together in terms of transforming lung cancer care has just absolutely been amazing to watch.
You also have obviously been deeply involved in treating mesothelioma.
Then I said to myself, well, if I'm going to get referred this group of patients that no one else wants to take care of, I better learn something about the disease and see if we can improve our therapies. Then, thanks to the scientific environment at MSK, we had the opportunity to create tumor banks, to begin to study the biology of the disease, and to do multidisciplinary clinical trials.
I could imagine that such a collaborative mindset would be invaluable when you became the president of the American College of Surgeons at the start of the COVID pandemic.
The COVID pandemic hit in the middle of my presidential year, I was actually in Egypt when COVID hit New York, and had to repatriate pretty abruptly. And of course, it's incredible for us to think back now to March of 2020, when none of us knew what to do. And the surgical world was in a quandary about what do we do? Do we continue to operate? Do we close everything down? So very, very quickly, starting about a week after I got back, we pulled together the executive leadership of the college and decided that the very first thing that we should do was to set up pathways of communication with fellows to provide clear scientific evidence about how to manage this problem, because as I'm sure everyone will recall, there was a lot of inaccurate news circulating at that point in time.
Can you share more about your involvement in these global health and global outreach initiatives, particularly your work in the sub-Saharan Africa?
We had a program called Operation Giving Back, which really was focused on linking interested surgeons to NGOs and other organizations that were providing clinical care, either domestically or internationally, to underserved areas. David Hoyt and Patricia Turner very wisely recruited Dr. Gurma Tefera, who is an emeritus chief of vascular surgery at the University of Wisconsin, but an Ethiopian by birth, and he has decades and decades of experience in global surgery. And they recruited him to lead what is now known as ACS Hope, Health Outreach Program for Equity. Within the regions, we had talked about how to focus this program, because you can't save the world in a day, and decided that the most highly underserved area to focus on initially would be sub-Saharan Africa. And ACS Hope is very, very different from OGB. It is a program focused on the sustainable, or the development of sustainable programs in clinical care, surgical education, and research in these countries. And after a very rigorous process, there were 3 sites that were selected as the initial, what we call educational hubs for the program, one in Hawassa, Ethiopia. It's really important to take those guiding principles that you learn in training, but to understand that they are the foundation for lifelong learning, and to be open to evolution. It's painful to learn new surgical techniques. I've been there and done that multiple times through my career, and to go from being doing only open procedures to learning VATS, and from VATS to learning robotic, and to learning robotic bronchoscopy, all these newer procedures that we do, you have to have a certain level of humility and willingness to learn, and to learn from others, actually.
You are a true surgical investigator, and everyone knows you're a master surgeon. This is, in fact, iconic, and your father, I think, was correct. No one can argue with excellence. And I just want to thank you for being a great mentor and a great surgeon and a great leader for us today.
Well, thank you so much. And again, it's been a pleasure and a privilege.
Thank you.